Hi, everyone. We'll get started in just a couple minutes here. Okay, everyone, let's get started. Thank you so much for joining us this afternoon on our webinar. This is actually our 9th webinar in our series. Today's topic is withdrawal management or detox and continuing care. My name is Amber Biddle, and I am the Corporate Clinical Director for Firetree Ltd. And our webinars are just an effort to educate family and community members about addiction and addiction treatment. So we really appreciate you joining us. If you have any questions about Firetree or questions in general, you can put them in the Q&A box, and we'll kind of circle back at the end to answer any questions that you might have. I also have some information in the footers that might be helpful to you, including the Firetree website, our past archives, and our admissions number. So our objectives today are to just briefly discuss an early history of addiction treatment. From there, we'll talk about different levels of care and more about what addiction treatment looks like today. Then we'll discuss what is withdrawal management, what is continuing care, and then the importance of continuing care and protecting against relapse. Okay. So early addiction care. You'll notice that early addiction care really focuses on alcohol. And then a little bit later, we'll kind of transition more into substance use in general. But there have been grassroots interventions from as early as the 1750s to the early 1800s. And those groups were actually organized and originally comprised of various Native American tribes, which then evolved into abstinence-based Native American revival movements. And that was really some of the first community efforts to manage substance use and abuse. Interestingly, too, Native Americans use Native healing practices to treat alcoholism. And as far as alcohol use in colonial America, alcohol has been consumed since colonial times, where it was an integral part of culture. The production and consumption of alcohol increased steadily, and by 1810, the number of distilleries in the United States had increased to over 14,000. The level of alcohol consumption reached its peak by 1830, with the average American consuming approximately 5 to 7 gallons of alcohol per year. Alcohol had become easily accessible and affordable to the general population, making it a significant public health concern. So in the late 18th and early 19th centuries, individuals suffering from alcohol addiction were typically held in local jails and drunk tanks, almshouses, and asylums, none of which provided treatment to these individuals. And interestingly, I found that the jails actually served and continue to serve alcohol to the individuals. Hospitals were an option for medical treatment, but the hospitals were really limited during the 18th and 19th centuries. Benjamin Rush was a prominent physician, and he was really committed to educating the public about the hazards of alcohol consumption. And he was one of the first to propose sober houses to be used to treat alcohol addiction through medical treatment, as well as, quote, religious and moral instruction. Rush went on to describe the symptoms and potential social consequences of alcohol abuse in pamphlets that he then distributed to the public. His written works helped launch the beginning of the temperance movement, which we'll talk about next. At this time, doctors were also identifying physical consequences of withdrawal and alcoholism itself. Dr. Magnus Huss was one of the first to coin the term alcoholism in the mid-1800s. The identification of physical side effects and consequences of chronic alcohol use and the push for abstinence as a response were factors which led to institutional treatment of alcoholism. The American Association for the Cure of Inebriation was the first attempt at the professionalization of treatment services. So now we're going to see a big change in conceptualization of addiction and therefore in addiction treatment with the temperance movement, which began in 1808 as a response to the social problems resulting from the rapid increase in alcohol abuse among the American population. It led to a new way of viewing addiction and recovery, which, like I said, impacted the evolution of substance abuse treatment. Alcoholism during this time was thought to be a moral affliction rather than a disease or an illness. Therefore, the original goal of the temperance movement was reduction, a decrease in drinking. Beginning in 1831, temperance societies, for example, the Washingtonian Society, were formed throughout the country in an effort to promote communal recovery. And many of the purposes of this society were similar to modern day community-based support groups like AA or NA, and that alcoholics would meet, they would hear lectures, and they would discuss their experiences of alcoholism and recovery. Generally speaking, the goal of prohibition then was to make the distribution and transportation of alcohol illegal, to ultimately impact the consumption of alcohol in an effort to diminish alcoholism as a social problem. Unfortunately, the impact that had was that alcohol abuse rose while treatment options disappeared. Previously, we were seeing a bit of the idea that alcohol was a physical illness that necessitated medical treatment. And again, that was replaced by the belief that alcohol was a moral character flaw that could be cured by just prohibiting drunkenness. As a result, religious groups continued to provide treatment services to alcoholics during this time period. Interestingly, the Salvation Army was providing treatment to alcoholics, but institutional treatment of addiction completely disappeared until the 1940s. The 1950s and the 1960s. So after the enactment of the 21st Amendment in 1933, prohibition ended and kind of a new phase in the treatment of alcohol addiction began. During this time, once again, alcoholism was thought of as a disease and a public health issue, and we were moving away from the moral weakness ideology. So both professionals and members of society alike began to think that alcoholism could be treated. This new belief in the benefits of the treatment opened the door for the distribution of money for new research on addiction to be conducted by medical and psychological professionals. So still early in the 1930s, though, treatment options for alcoholics had all but disappeared. In 1935, Bill Wilson and Dr. Robert Smith developed a self-help recovery group called Alcoholics Anonymous in an effort to fill that treatment void. Bill Wilson and Dr. Bob were both alcoholics who were unable to achieve sustained abstinence despite their Christian faith and their membership in the Oxford Group, which was a Christian organization whose principles heavily influenced the creation of the 12 steps. The meeting between Bill W. and Dr. Bob in 1935 marked the formation of AA, and the famous blue book, Alcoholics Anonymous, was published in 1939. AA separated from the Oxford Group in the 1930s. So both the founding of Alcoholics Anonymous and the growing acceptance of alcohol abuse and alcoholism as health problems were pivotal events in helping to reintroduce the national policy debate on alcohol-related problems. The success of AA helped to demonstrate that alcoholics could recover. The National Committee for Education on Alcohol was founded in 1944 by Marty Mann, who was the first woman to recover through AA, and also founded by researchers and physicians from Yale University. This committee called for hospital admissions, alcoholism centers, and rest centers to resume institutionalized treatment of alcoholism. By the 1950s, major healthcare organizations such as the American Medical Association and the World Health Organization began to address the healthcare aspects of alcoholism and the discrimination against alcoholics in healthcare settings. By the 1960s, these groups were joined by the American Psychiatric Association and the American Public Health Association in declaring alcoholism an illness. Okay, this is our last component on history of addiction treatment. The Minnesota model of addiction treatment began the establishment of a new method of alcoholism treatment in 3 Minnesota centers in the late 1940s: Wilmar State Hospital, Pioneer House, and Hazelden. One of the primary tenets of the Minnesota model was respect rather than degradation, which was a radical idea during this time period. The staff at Wilmar defined alcoholism not as a symptom of underlying emotional problems, but as a primary progressive disease that should be treated using a multidisciplinary and holistic approach. Medical treatment was to be provided by doctors and nurses. Counseling was to be provided by psychologists and social workers, and spiritual guidance was to be provided by the clergy. We also see the beginnings of pharmacotherapy during this time period with the development of disulfiram and other drugs used to treat alcoholism. Disulfiram, otherwise known as Antabuse, was introduced in the US as a supplemental treatment for alcoholism, which created feelings of nausea and unpleasant reactions to alcohol. So here we see some pretty essential components of modern treatment, the origins of those, including structured treatment, multidisciplinary treatment, the use of MAT or pharmacotherapy. And I thought that was pretty interesting to give us some context for talking about treatment today. The one other thing that I wanted to mention about their contributing to how treatment looks today was that there was the declaration of the American Medical Association that alcoholism is a disease suggested that alcoholism was a medical problem, thus requiring medical intervention. So in 1971, the Uniform Alcoholism and Intoxication Treatment Act was adopted, which recommended that alcoholics not be subjected to criminal prosecution because of their consumption of alcoholic beverages, but rather should be afforded a continuum of treatment in order that they may live normal lives as productive members of society. So I thought that tie-in was really important when we're talking about levels of care and what levels of care are. So you'll see I have the levels of care listed there from level 1 to level 4. So that is least intensive treatment to most intensive treatment. And the reason that we need different levels of care is because substance use disorder looks different for every person. It can impact anyone regardless of their age, ethnicity, income, occupation, location, gender, or religion. Every person is unique, which is why the care provided by treatment facilities needs to have various levels to accommodate every individual who needs help. People can have various intensities of addiction. The severity of addiction can depend on the drug or drugs, the length of substance use, and any co-occurring mental health conditions. I wanted to note too that there is a level 0.5 early intervention services in addition to the levels of care that we'll talk about today. But since that's more of prevention, I won't address it in this slideshow. So we'll start with level 4 and level 3.7 withdrawal management. But what is withdrawal management? So withdrawal management is a set of interventions aimed at managing acute intoxication and withdrawal. So the terminology that used to be used was detox, which references the clearing of toxins from the body of an individual who either is actively under the influence and or is dependent on a certain substance. So the Washington Circle Group defined detoxification as a medical intervention that manages an individual safely through the process of acute withdrawal. The WCG makes an important distinction, noting that a detoxification program is not designed to resolve the longstanding psychological, social, and behavior problems associated with alcohol and drug abuse. The detox process, so level 4 and 3.7 that we'll talk about in just a minute, generally has 3 components that can take place either step by step or concurrently. The first one of which is evaluation, which involves testing for the presence of substances and measuring their concentration, as well as screening for co-occurring mental health and physical health conditions. Evaluation also includes a comprehensive assessment of the patient's medical and psychological conditions, as well as their social situation to help determine the appropriate level of treatment following detoxification or withdrawal management. Stabilization then includes the process of assisting the patient through intoxication and withdrawal to medical stability. It's often done with the assistance of medications, although not always. And stabilization too includes familiarizing patients with what to expect in treatment and their role in treatment and recovery. During this time, counselors or other staff can also seek the involvement of the patient's family, employers, and other significant people. Fostering the patient's entry into treatment is the last component, and that involves preparing the patient or individual or client, whatever terminology that you would like to use, for entry into substance abuse treatment by stressing the importance of following through with the complete substance abuse treatment continuum of care. All 3 components involve treating the patient with compassion and understanding. Individuals undergoing withdrawal need to know that someone cares about them, respects them as individuals, and has hope for their future. So specifically, And that leads us to level 4, which is medically managed intensive inpatient services. So this generally takes place in an acute care general hospital. It can also be a psychiatric hospital or psychiatric unit, or a specialty addictions treatment hospital. Individuals that need 4.0 level of care are individuals that need withdrawal management and also generally have a medical, emotional, behavioral, or cognitive disorder that requires 24-hour medical treatment, observation, and monitoring. This compares to level 3.7 withdrawal management level of care, which generally is an inpatient setting, but can also be a specialty unit in a general or psychiatric hospital. Individuals who need treatment at a 3.7 withdrawal management level of care typically are having pretty severe withdrawal symptoms, but not so severe that they require 24-hour care or the full resources that we talked about that the hospital that 4.0 could provide. Observation, monitoring, and treatment are available. And again, the primary focus is on stabilization of withdrawal symptoms and also education about continuing care. All right, 3.5, clinically managed high-intensity residential services, so rehab. Usually a freestanding facility in a community setting. It involves the use of a therapeutic community, and length of stay is variable. We used to think of rehab as, a 28-day program, a 60-day program, and that's not the case anymore. It depends on a lot of different factors, including response to treatment and severity of symptoms. Individuals who need 3.5, their addiction is so out of control that they are at imminent risk of relapse and typically harm to themselves. A lot of times there are concerns with housing, their support system, they have a high relapse risk, and there's usually some additional emotional, behavioral, or cognitive concerns. Treatment focus is on the development and application of recovery skills, increasing their understanding of their addiction, their substance use disorder, as well as any mental health diagnosis that they might have, and assessing and enhancing their readiness to change. So really working on their motivation to stop using substances, and helping them form a plan for how they're going to do that. Next, we have 3.1, clinically managed low-intensity residential. So those are facilities like a halfway house, a group home, or other supportive living environment that are staffed 24/7, typically in a community setting. Individuals that need 3.1 treatment generally need time and a structure to practice and integrate their recovery and coping skills in an environment that is still supportive and provides a lot of accountability. Or individuals who their living environments, their home environments, or original housing situation are incompatible with their recovery goals. So that could look like somebody who is unhoused, or somebody that maybe has other folks living at home that continue to use substances. Halfway houses, 3.1, continue to have weekly clinical services to improve readiness to change and coping skills. There's typically a vocational rehabilitation and life skills component. There's work on interpersonal and group living skills just by nature of the facility. And generally, there are introductions to the larger recovery community through meeting attendance locally A lot of times that can look like AA or NA attendance, but it doesn't necessarily have to be. Level 2, so I combined partial hospitalization 2.5 and intensive outpatient services 2.1. So 2.5 includes day treatment programs. An IOP can be after school programming, day or evening, and also weekend intensive outpatient programs. So can be a lot of flexibility with those. Level 2 is generally for folks that have achieved some stability, but they need continued education on their addiction and treatment components while they still have some freedom and are learning to apply those skills in like a real world or more organic environment. Partial is at least 20 hours per week compared to intensive outpatient, which is 9 to 19 hours a week. Consists of individual and group therapy. The client works with a counselor to build a treatment plan that focuses on their needs and areas that they would like to improve in. And generally, psychiatric and medical services are addressed through consultation and referrals. Again, length of treatment can vary. And lastly, level 1.0 are outpatient services. Setting can be office practices, mental health clinics, school-based programs, primary health care clinics, addiction programs, and mental health clinics. So folks at level 1.0 can look a little bit different. So it can be people who recognize their addiction and are committed to recovery. It can be people who might not have much interest or motivation to change, but are stable in other areas, medically, emotionally. Maybe they do have a living situation at home that is supportive of recovery. Or people in ongoing recovery who need monitoring and continuing disease management, just the accountability, and they're kind of tapering off at the end of their professional services. Outpatient services are usually fewer than 9 hours a week. Maybe an initial level of care, so someone may enter treatment at this level of care or be a step down from a more intensive level of care, which we'll talk about in just a second. It oftentimes allows earlier access to care of individuals who are in need of treatment. And again, an individualized treatment plan and length of treatment time vary. So our last component here is continuing care and what that is and why that's important. So continuing care is a phase of treatment that follows more intensive care. So aftercare and step-down care are also used interchangeably. So continuing care is to help strengthen recovery skills, help folks stay accountable, and help them maintain motivation to stay sober. A lot of times when they have more freedom and are able to make more of their own choices or are in less structured environments. Counselors can recommend varying lengths of continuing care or at different levels depending on the needs after the initial treatment is completed. So aftercare can look, or continuing care can look a lot different depending on the person, but generally includes relapse prevention, developing new healthy behavior patterns, connecting people with uplifting and accountable support systems, and assistance with challenges related to maintaining sobriety. So that can look like employment problems, housing problems, relationship stressors. Just working on helping people navigate those so that they can maintain their recovery. And why is it important? So continuing care, aftercare takes into consideration that addiction is a chronic and relapsing condition. And according to the National Institute on Drug Abuse, successful recovery from drug and alcohol addiction is a long-term process. So continuing care kind of meets that idea. The individual's aftercare treatment plan can include a lot of different components that's based on their needs, including employment services, medication for addiction treatment, family counseling, and social or legal services. And continuing care is especially important for individuals with physical or mental health issues and that lack support at home or in their communities. So all that to say is that continuing care is important for giving folks their best shot at sustained recovery and improved quality of life. And continuing care can look different for a lot of people depending on their needs. As we wrap up here, I'll see if there were any questions in the chat. Okay, no questions. If you have anything, you can enter it in now. I'll pause for a couple seconds. Okay, otherwise, thank you so much for joining us for this webinar. I hope that was interesting or you learned something. Our next webinar is scheduled for the 20th, and we're going to stick with the noon time. That seems to work well for most people. I have our Firetree website listed down at the bottom if you're interested in our services. And we'll be sending out an email within the next few days, early next week, about what our topic is for next month. But again, thank you for joining us, and we hope to see you again at our next webinar.